because I'm not a morning person and I'm still in my pajamas drinking coffee. So I didn't figure that was a sight anybody wanted to see. But I was asked to give a talk about specifically like ATV injuries, but I thought that might be difficult to do for 45 minutes. So I did kind of a basic pediatric trauma evaluation and management presentation, and then there will be some specific concentration on ATVs at the end. And I apologize in advance for my dog. He's doing his morning neighborhood watch. Walter, knock it off. Sorry. So we'll start by saying, everybody says children are not little adults, right? When we take care of them in the pediatric population, that we can't just treat them, the same fluid management, et cetera. But for trauma, patients are little adults. Because there's really no difference there's no such thing as a pediatric ATLS, and we'll get to that later. But the objectives of our talk today are to highlight the important differences that there are between adults and children, highlight safe practices and an evidence-based approach, and to realize that this is all under constant evolution, right? Recommendations for even how we manage IV fluid resuscitation, when to use blood, et cetera, are recently changing. So this talk kind of focuses on what the receiving doctor from another hospital or another department wants you to have done. Tips and exceptions are always great to know, but a solid standard trauma workup is the safest and most acceptable method to treat these kids. So again, there's no pediatric ATLS, there's just ATLS. You do what you know, and just remember, in particular to trauma, we're not talking about NICU patients, we're not talking about PICU patients with chronic trachs. These are trauma patients first. So some background, trauma is the leading cause of death in patients under 19. A few years ago, they kind of muddied this data and they said 1 to 19, because if you included under 1, that included all the neonatal deaths and all that weird stuff that the tiny babies have. And if you excluded 17 to 19, the numbers changed as well. But if you look at it now, even just 1 to 17, trauma is always the number one cause of death for that age group. Gun violence is now the number one method of trauma death in these kids, even if you narrow it down to 1 to 17 and exclude the 18 and 19-year-old kids. So MVC, outside of gun violence, car accidents, drowning, suicide becomes the number 2 cause of traumatic death from the ages of 14 and above, unfortunately. So kids that are going to die from trauma usually die before they ever get to the hospital. So there's a big focus on pre-hospital care, EMS. They're starting to carry new things on the ambulances, TXA. They're starting to carry blood on the ambulances, things like that, right? Because that's where most of the mortality happens. And trauma in pediatric population accounts for over 9.2 million ER admissions per year. This is just the firearms data. You can see it kind of started to change around COVID. I don't know if that's coincidental or not. I would imagine not. But right around 2020, firearms took over as the most common cause of death in our pediatric population for trauma-related. But that being said, most typically, blunt is more common than penetrating as a form of trauma, not necessarily trauma death, just as a form of trauma in the pediatric population. Blunt is far more common than penetrating. TBIs, there's lots of them. Anybody who works in our hospital or really any children's hospital knows this. Getting hit while you're on your bicycle, that happens a lot, right, to our younger kids. All of these numbers should look familiar to you if you take care of kids in our hospital, right? If you think about the ages of the kids you see with these diagnoses, I mean, it's not surprising when you sit and think about it. But traumatic injury mortality is decreasing, and I think that's a lot due to improvements in ATLS, improvements in training, just all kinds of advances that are being made. So that is the good news after a series of really depressing slides. So just to kind of work through the trauma algorithm, this is like a typical patient we would see that comes into the ER, right? A little girl, restrained passenger, high-speed MVC, didn't pass out, pulled out of the car by EMS, but complains of a headache and belly pain on arrival. And so the question is kind of just a basic workup, and how do you approach this patient when they first hit the door? So I'm sure all of you know primary survey for trauma, ABCs, right? So one is the airway. And again, children are not little adults when it comes to trauma. However, we will discuss some of the differences, right? They have bigger tongues. Their larynx is more anterior than adults, and so the epiglottis is also floppier, which makes it more challenging, I guess, to intubate them if you're not used to intubating just kids, which a lot of our ER providers are. The most narrow part of the airway is the subglottis, so right below the epiglottis, and the trachea is shorter, right? So when you're intubating these kids, you don't just shove the tube into like 10 centimeters. You got to think about it because you're going to right main stem them or potentially even injure the trachea. So chill out a little bit when you're intubating and putting that tube into the airway. Cuffed or uncuffed, that's always a good question, right? It depends. And a little bit of an air leak is not that bad. If you're working against some sort of external pressure and you can't ventilate the chest very well and you've got a huge air leak, then you might need to blow up that cuff, right? So it just depends clinically. I really don't know what EMS defaults to, cuffed or uncuffed. I would imagine cuffed if I had to guess in kids, but there's really no right answer. The concern with the cuff tube is if you leave that cuff up or inflated, it can cause, it's basically a pressure injury on the mucosa and the lining of the trachea, which can later lead to stenosis of the trachea, right? So you can use a cuff tube, but take down the cuff if you don't need it to reduce the pressure on the trachea. There's all the calculations for tube size, and honestly, thank God for the ER providers, because if you asked me these formulas, I wouldn't be able to tell you. I kind of have an idea of what size ET tube a kid needs based on their age, but they do have these little formulas. Basically, the size of your little finger is what I think about. And then again, always think about tube depth. It doesn't have to go very low, especially in these little kids. If you're in at like 6 or 7, that may be deep enough, right? Or too deep. And so the best way to figure that out, 1, look at chest rise, and then 2, listen to both sides of the lungs, right? Do you have breath sounds on both sides? If not, you probably need to pull it back a little bit. Surgical airways in children, no. Needle crike is about all we would do. And quite honestly, you want to, this is a question people ask in ATLS all the time when I teach is, well, what age can you do a crike? And the age varies. Some say 8, some say 12 years old. So definitely not in the little kids. However, you can do a needle cricothyroidotomy in basically anybody. And that is basically going through that same cricothyroid membrane, but instead of enlarging it and trying to shove an entire ET tube through there, you just use the needle, take out the inner cannula, leave the catheter in, and then you hook up your airway tubing to the catheter. There is no taping method that is going to keep this thing in place. So once you've got it and you can ventilate the child with it, there's no taping. There's a person that holds that catheter in place 100% of the time until you get them somewhere and they get a definitive airway. So don't fool yourself into thinking that you're going to tape a little 18 gauge catheter and it's going to stay through the cricothyroid membrane. Okay, there's a person holding that catheter because again, you have airway tubing connected to it. It's gonna get pulled out if you don't hold it in. The biggest thing I think to remember about an airway is if it's not an emergency, don't make it one. So if you can use a BVM and you can mask the kid and you're getting air exchange and the kid's not blue, then you can breathe for a little bit and figure out what to do about the airway. Don't rush into cutting into the neck and shoving tubes down before you've suctioned or have all your stuff ready. Just if it's not an emergency, don't make it one. So B is next, right? Again, differences between adults and children. Children's chest are more thin and compliant. So pulmonary contusions are more common. The mediastinum is also very compliant. Aortic injuries, therefore, are rare. They still have the same fixation points, right, at the ligamentums and all that other kind of stuff that can tear the aorta, but they're just a little more bouncy. And so I guess that's rude to say, but kids are bouncy, whatever, they bounce more. So mediastinal injuries are a little bit more rare. Rib fractures in children are also pretty rare if they're younger because, again, they're so cartilaginous, they're not completely ossified yet. And so if you see a rib fracture in a younger child, that means that there is a significant amount of force that child endured. So look for associated injuries, and rib fractures should always set off a red flag for you to consider child abuse. And don't forget to put an NG tube in on these kids because it's not uncommon that we see them go to CT scanner like this, right? The Scout X-ray on a CT, or when you do the babygram in the trauma bay, that we've been bag valve masking them and you're filling their stomach with air and you're not decompressing them. 1, that makes their abdominal exam a little bit harder to figure out. And 2, it can actually impede your ability to ventilate a patient, right? If you have a huge stomach pushing up on your diaphragm, like when you eat too much at dinner, right? And you like lay down, you're like, oh man, I can't breathe. It's kind of the same thing, right? You have this big full stomach and you can't make the child breathe if you're trying to ventilate them. So don't forget the NG tube. These are just some stats. Intrathoracic injury, 6%. Again, pretty rare for pediatric trauma patients. Chest tubes required, though, in 50% if they do have a major thoracic injury. The thorax itself is actually usually uninjured, which we already talked about because the ribs are soft and spongy. More pulmonary contusion because the force is getting transmitted into the actual lung parenchyma instead of being absorbed by the ribs. And then obviously increased work of breathing. Just a picture of a tension pneumothorax. I think everybody should be able to recognize this if you're dealing with kids that are traumas or potentially on the floor, or even if they have a chest tube in, right? Just because the tube is in doesn't mean it's working. So if you have a kid with a chest tube who's having increased work of breathing, you need to troubleshoot that chest tube first and make sure it's actually working. And then if they're still having trouble and getting worse and worse, put in a second chest tube. Presence of chest tube does not mean that chest tube is good. So what size chest tubes do we use? The one that fits is the answer. The one that does what you want it, and the one that does what you want it to, and the one that will go in. The same, I guess putting in a chest tube is maybe out of the scope of this talk, but there's some slight differences of how we put them in kids versus adults. Little kids, about a 16 French. The bigger you get, 20, 24. Teenagers are adult-sized humans, as I call them, so they get adult-sized tubes. I have a bias towards pigtail catheters instead of the big tubes in kids. There's data to show that pigtail catheters work just as well as the stiff chest tubes, right? And so they're more comfortable, they have less pain, and these kids are going through enough already. So why have this hard, rigid chest tube when you can use a pigtail catheter to evacuate simple pneumothorax, okay? If there's blood and other stuff in there, those catheters do get occluded, but if it's just a traumatic pneumothorax, I would prefer to put a pigtail in that kid. Always remember, for people who are putting these in, to stay away from the breast bud, right? If you get too close to where the actual breast bud or breast tissue is, even in a little kid, this is what you end up with later. So stay lateral. Just make sure you're in the chest. Don't go lower, because then you're going to end up in the liver if it's on the right. So don't go lower, just stay lateral. We probably don't need to talk about that. Okay, so circulation. Where do you feel the pulse? In infants, the only thing that's different, feel it in the brachial arteries. In children and bigger kids, you can feel them wherever, right? Carotid, radial, femoral, pick your poison. Just a difference in pulse rates, right? People sometimes in the ER, depending on who's covering, will be like, oh my God, the kid's tachycardic, they have a heart rate of 160. And it's like, well, the kid's 3 months old, so that may not be abnormal for them. And then also when you're talking about resuscitation and circulation, I'll have residents come tell me, oh, their urine output is fine. It's 0.5 cc's per kilo per hour. And I'm like, well, that's great for an adult, but that's actually not enough for a smaller kid. So little kids need to make more urine per hour and their pulse is higher. And these things shouldn't be too scary. And systolic blood pressure, a lot of you guys are pediatric providers. And so these numbers are not scary to you, but they can be very disconcerting to other providers who don't work with kids all the time. So when you get called and asked about stuff, just remember, this is one of the ways that kids are different than adults, but it doesn't mean that the principles of treatment are different. So again, tachycardia, hard to interpret. Bradycardia is always bad. That means baby's trying to die, so we need to do something about that. Another formula for you, memorize it if you want to. I don't. Newborns, MAP is the easiest thing to use. So their mean arterial pressure, and I do this when I roll through the NICU, whatever their gestational age is, right? You'll walk in and people will be like, oh my God, the MAP is so low. And it's like, well, the baby's only 28 weeks. And so a MAP of 28 to 30 in that kid is fine. And then, just physical exam findings, right? Cap refill, distal pulses, is the baby pink or blue, is usually a pretty good indicator of how well resuscitated or, how well the baby's doing just in general. This is a very boring chart, and actually it's a little bit out of date if you look at the very bottom where it talks about fluid resuscitation for trauma. Again, things are constantly evolving, right? And so I think most people would say give one bolus, and if they're not responding, okay, repeat times one, but you really need to be getting blood. So some people might say 120 cc per kilo bolus of crystalloid and then go immediately to blood. Other people might say, okay, you can repeat it once and then go to blood. You should start with PRBCs depending on where you are. So if you're lucky enough to be at UMC and we have whole blood for a massive trauma patient, use the whole blood. You usually have to activate the massive transfusion protocol to get that done. If you think your kid just needs a little bit of blood, give PRBCs. But we get transfers all the time where kids have gotten like FFP and they've gotten cryo, but they never got PRBCs. So all of those adjuncts don't really help you when you're a trauma. You've lost blood. You haven't just lost FFP. And the most important part of losing blood and replacing blood is giving oxygen carrying capacity back, right? Which FFP doesn't do, but blood cells, that's their entire job. So I don't mean to be condescending, but give blood to the bleeding child. Don't give FFP and the other things. And again, remembering these little kids, I mean, a little newborn baby, about 80 to 90 cc's per kilo is their entire circulating blood volume. So if you have a 3-kilo baby, their entire blood volume is about 250 cc's. So that's a quarter of a liter. And so we're used to in the OR saying blood loss. Well, not we, the adult surgeons in the OR are used to saying, oh, blood loss, 100 cc's. If I lose 100 cc's in a newborn baby, that's half of their circulating volume almost, right? So keep in mind those volumes are way different when you're talking about smaller children. MTP, we kind of talked about it. We have a whole protocol here. There's an ABC score, and I can't remember why it's called ABC because the mnemonic doesn't make sense in my mind. But if they're hypotensive, tachycardic, have a positive FAST, have penetrating injury, if 2 of those things are present, then you should activate your MTP. It does overestimate the need for MTP, but there are better outcomes, right? Because you're probably over transfusing people. So more people live. It tends to over transfuse people as well. And so you kind of end up fighting that 2-3 days later when you've over resuscitated them. But that score has been validated to, quote, save lives, granted with a little bit of work, like I said, 2 or 3 days later to kind of fix the overcorrection. But anyway, we do have an MTP protocol here. It does involve sending I think I have it. Yeah, there you go on this slide. What comes down when you start activating MTP. This is at our institution. I'm sure other institutions are different. Other institutions don't have whole blood. So your first cooler will be whole blood, and then they start fractionating it after that in the second cooler. So if you're in the ER, this is kind of what you can expect. But for kids on the floor, you can also make a special request for whole blood, and it's gotten a lot easier for us to get that than it was even 2 years ago. So access, IVs are preferable, obviously. Central lines can be hard in smaller children. The femoral is harder to get than you think because they're chubby and have thick thighs. They got little thunder thighs on them, and so it's sometimes hard to even palpate the femoral artery to find where the femoral vein would be. The IJ is nearly impossible in an awake screaming child. Ultrasound increases safety and efficacy. We know that, but if you think you're going to get a trauma child to lay down, turn their head to the left, put the ultrasound on there, stick them in it's not going to happen. So subclavian is my preferred for emergency access, and usually what kids will show up with if they're a trauma from the ER. Now, if they're in the PICU getting a line and they're chilled out or intubated and sedated, completely different, and a lot of those kids get femorals. An ATLS question, I think it's the only PEDS ATLS question on the test, is, they send you through this whole thing and nobody can get IVs, and the answer is just to put in an intraosseous line. You can deliver anything through an IO that you can deliver through an IV. You can give blood through an IO. You can give paralytics through an IO. You can give any medication through an intraosseous line that you can give through an IV. So it is a great alternative when you can't get intravenous access. Secondary survey. So disability is what the D is for, right? So pupil exams, the pediatric Glasgow coma scale is different, right? So adults, it's like eyes, verbal movement, right? And so verbal for a baby is not oriented to place, right? It's like, are they cooing or are they like completely passed out? And this is just a little mnemonic I learned as a fellow, that if baby cry, baby don't die, but if the baby's blue, mom is gonna sue. So make sure the baby, again, is nice and pink, and breathing, right? If you're there, then you got something. If the baby's blue, that's never, ever a good thing. And then exposure, right? So a head to toe exam, and then this is kind of secondary survey, but it's basically gets repeated again when we do a tertiary survey. So head to toe exam, look at all your films. Every trauma really should get a chest and a pelvis x-ray. C-spine is plus or minus mechanism. Most of our kids come in a C-collar, and if somebody thought to put them in the C-collar, my thought is I need to clear their C-spine in some way. That doesn't necessarily mean an X-ray. It certainly does not mean a CT of the C-spine, but it does mean at least using, we'll talk about some of the nexus criteria and things next, to clear their C-spine and at least pay attention to it. But a lot of the kids ultimately will get a 2-view C-spine X-ray. And then anything that hurts and anything that has a big bruise or something on it, you're going to want to get an X-ray. So a little bit about fast exams. I don't use them. The ER is very big on them. I think more for training because ultrasound is always user dependent. Fast exams they still have, there are some studies you can find that show that a little bit better numbers than the sensitivity of 50 and specificity of 85, which sucks, right? Like nobody wants to use that test. As people are getting more facile with it, hence the practicing in the ER, those numbers have come up, but they still don't seem to be especially useful. Like, okay, you have a positive fast exam, the kid's stable, they're going to go to the CT scan. Those kids usually have findings on exam, right? A tender belly without peritonitis, they're going to go get a CT scan anyway. So I'm not really sure the utility of the fast exam. That's great that you have a test that works, but does it change your clinical management? And the answer is not really. So, I mean, if you have a kid with peritonitis who's dying and has a fast exam that's positive, you're going to the OR anyway, right? So I'm not sure that fast exam changed anything for you. So I'm anti-fast, as you can tell, but I try to be polite while they're doing all the fast exams in the ER, because I do understand the utility of repeated use and getting more facile at it. But in peds, there's not a consensus that it's either good or bad necessarily. And here's some papers for you. This one's a little bit older, but again, some of the papers have better numbers now, but again, does it really change how you clinically manage that child? And I am a huge proponent of evidence-based medicine. And if it's not changing what I'm going to do next, then I don't think that I need to use that test. So additional imaging, this is a big one, especially for outside providers and when kids get transferred to us. I think that in adults, we're just used to getting CTs and we don't really think about it, but there's a significant amount of radiation that these kids get exposed to. And this whole idea of just pan scan the kid and getting chest CTs and head and neck CTs and stuff when we don't need them comes at a significant cost. So the MSV or millisieverts, which is the unit that we use to talk about radiation. I mean, you can just see the numbers, right? Like chest X-ray 0.1, but you start going into CTs and you've like made that 200 times greater, right? Like with 20 millisieverts. A CT of the chest, not as bad, but you know, if you do the abdomen and the pelvis, and then you do a chest and an abdomen and a pelvis, and then you do with and without contrast, all of that increases the radiation dosages that these kids get. So a single CT abdomen pelvis will get, like the last slide said, over 20 millisieverts of radiation. The brain dose, if you get over, which is over 50, puts you at a 2.8 times greater risk of brain cancer as a child, right? Because you're going to live longer. So the damage that occurs to those cells have like 80 years of time to degrade and like miss a DNA sequence or whatever, right? When it's replicating and cause a cancer. So that's why these risks are higher, is because kids live longer. A bone marrow dose is 30, and that's 3.2 times greater risk of a leukemia, right? So like the risk that you're increasing is not inconsequential. Thyroid cancer can be 2.5 times more. Lifetime risk of fatal cancer, I mean, 1 in 500 for an abdominal CT, like pass. Like if I don't need one, I'm going to pass on that, right? So I wish that outside providers would think about this more, especially before if you need a head CT, okay, fine, but that doesn't mean you automatically need a C-spine. And that's something I fight with the ER about all the time. Why don't we get the head CT? If there's no injury there and the kid has got a normal GCS, we can either get a 2-view X-ray or we can clear them clinically, right? Like, oh, well, they're already in the scanner. Well, that's not a good enough excuse for me to give the kid a lifetime risk of fatal cancer, right? It just doesn't make sense. Like, and I understand time and efficiency and whatever, but I really think that the focus should be on the child. And you can always send them back to the CT scanner. It's not that big of a deal. We already talked about that. Okay, so again, do not pan scan ever. You only send hemodynamically stable patients to the CT scanner. If they're unstable, you need to be doing something else. Meaningful thoracic trauma should be shown on a chest X-ray, and usually that's going to either make you put in a tube or go to the OR or do something else. And after you do those things, then you can get your CTA of the chest or whatever you need, right? Once they're more stable. So again, only stable patients go to the CT scanner. And then for the abdomen, we kind of alluded to this already, tenderness to palpation without peritonitis, because if they have peritonitis, they need to be in the OR. Elevated liver enzymes is a good indication, although if you have elevated liver enzymes and not a significantly impressive abdominal exam, you might hold off and admit that child and do serial exams. So that's not a hard sign. And same story with seatbelt sign, right? If the kid looks pretty stable and has a seatbelt sign and maybe their exam is a little tender, you could CT them. If you're going to send them home, would be my thought. So if I'm going to CT a seatbelt sign and the CT is negative, that kid needs to go home. You get people that have a negative CT and then the ER wants you to admit them. Well, then you shouldn't have gotten the CT. You should have just put that kid on the floor, done serial exams, maybe serial labs, and seen how the kid is done. Again, with the idea of decreasing the radiation exposure that these children get. This is just pictures of what seatbelt signs look like. I'm sure many of you have seen them and taken care of them. This is why it happens, right? This is why it happens to anybody, right? The lap belt compresses your intestines against your spine. But if you think about kids, they're skinnier and they actually have more of a lumbar lordosis. And so there's actually less space between the spine and the anterior abdominal wall. And so they're more prone to it than adults, actually. This is easier to see on the next slide, which has kind of the current protocol that we follow for solid organ injuries. Indications, again, for abdominal CT, not always. Like, you don't have to follow this 100% if clinically the child doesn't need it. We have a very high success for non-operative management of splenic and hepatic injuries in children. I'm not sure why they're not that high in adults, and I don't know if it's something physiologic about adults or if because the adults are a little bit behind in practicing non-operative management. But I suspect they must have worse injuries because they tend to look more in extremis and go directly to the OR. Our kids don't. We resuscitate them. We sit on them. They might go to IR, but even that is pretty uncommon for most of our solid organ injuries. This is the old atomic protocol that we follow, and I know it's a very busy slide. This just got updated, and we're working on updating it in our institution here in the next couple months or month or so, hopefully. But the biggest thing to kind of take away from this is that it's pretty liberal, basically. So you come in, you have a hemoglobin, and then you get 1 or 2 more hemoglobins only checked. This is different than what tends to happen. We still have trouble getting this implemented because people just obsessively check the hemoglobins. And we'll have kids that have like 6 or 7 hemoglobins that have been stable. And then by the 7th one, it starts to downtrend. And it's like, well, yeah, because you've taken, 80 cc's of blood off the kid with every CBC that you're taking. Not 80, but you know what I mean. And so I call them the ICU vampires, right? Like, oh, the hemoglobin drifted from 10 to, 8.5. Well, yeah, because the vampires are sucking blood from the child every day to do Q6-hour hemoglobins. And that's not necessarily indicated if the child is stable. And so that would be my biggest takeaway from this. And then we've gotten a lot more liberal as far as bed rest, right? So a lot of these kids, it used to be grade of injury -1. So you had a grade 3 liver injury, you were on bed rest for 2 days. Now it's like 18 hours or so. And overnight, say they come in at 2 o'clock in the morning, it used to be 18 hours and now we just say overnight. So if they come in at 2 o'clock in the morning, that's overnight, right? And if you think about what bed rest means in a 6-year-old child, I mean, they're flipping around in the bed like a wet fish, like they're crazy, right? Like I don't know what bed rest means in some of these little kids anyway. So I think we like to convince ourselves that we're, really taking big precautions and whatever. Then you walk in and the kid's like wrapped up in the blanket and half hanging out of the bed. And, I'm not sure that quote bed rest means anything. And I think that's why we've gotten more liberal on what bed rest means. This is the updated atomic protocol that we may or may not be following as we update this policy. And the interesting thing to me is the side on the left in the green, which is even more liberal. That one, some of these kids don't need a CT scan. And if they do get a scan and they are 1 or even a 2 solid organ injury, they don't have external bruising or signs, and they don't live like in the country, and they have access to care and transportation, those kids can go home from the ER. And that is my concern about us adopting this policy, because I think we might have a hard time convincing anybody in the ER or the PICU or anybody else or the adults overnight to send some of these kids home with a grade 2 liver lac, right? But I mean, this is all, Atomic is a consortium, and I can't remember the states. It's like, I don't know, Arkansas, Texas, Oklahoma, whatever. And everybody gets together and comes up with these things. So it's not just some harebrained idea, but has research behind it. So I find that very interesting that some of these grade 2 injuries, if they look pretty good and they don't have external signs and they don't live in Appalachia or something, that, they can go home. So that's interesting. The rest of it is pretty much the same as far as, when you need IR, what failure of non-operative management means, whatever. But the interesting side to me is how liberal we are with some of these kids based on these new protocols. So it gets pretty boring, this part of the talk. So if I rush through it, don't be offended. If y'all want to hear more, we can go back at the end. But renal injury is sort of the same thing. Hematuria, microscopic hematuria is an indication for CT cystogram. There's different thresholds for that. Widely accepted is over 50 blood cells per high power field. Some people will do it if there's any per high power field, which is interesting. And you got to think about the sample, right? Was this a voided sample or was it catheterized? Because that may in and of itself cause you to have blood in the sample. So anyway, CT cysto, if there's obvious hematuria, or microscopic hematuria, I guess I should say, and 50 would be kind of the widely accepted cutoff. You can selectively angioembolize the kidney. And a lot of the smaller kids, the renal artery is very, very small. So people will say, oh, there's a dissection, or, oh, it looks like it's thrombosed. Can we go in and do some IR stuff or stent it or whatever? They really don't make stents small enough to go across the renal artery like in a 6-year-old, quite honestly. And so if that kid has dissected his artery or thrombosed it completely and the kidney is out, there's usually very little to do about that. And as long as they're stable, most of the time you just let that kidney die, it will kind of resorb. There is in certain incidents, I don't know the number, of infection, right, when that renal parenchyma is dying, that may later need either debridement operatively or IR drains and things like that. But if they have their entire kidney out in a smaller kid, it is sometimes hard to even get a wire to do anything to try to open up that vessel again. So, but again, the preservation rates in children are very high. We don't really care about that, I don't think. Cerebrovascular injury, there are screening protocols. So again, the seatbelt sign across the neck, flexion extension injuries. So a lot of kids that have been shaken and their head is bouncing around on their neck, that can cause traction injuries on the arteries and cause intimal injuries. So different injury patterns make you suspicious. And then here, I think almost universally, we use the Denver screening criteria, which I'll show you on the next page. And then that results in a CTA and then thrombotic treatment. Again, it's even in adults, especially if it's an intracranial extension, you can't really stent those. If it's all extracranial in the neck, there are some stents that can work. But again, in a child they just don't make stents small enough. And there's obviously a risk of stroke and whatever with that actual doing that procedure. So sometimes it's not as helpful as you might think, but the child would have to be big enough to even consider it in the first place, which a lot of the times they're not. This shows that even using the most liberal screening protocol, we still miss blunt cerebrovascular injuries. And so you will notice that if a kid has like one sign, they will end up with a CTA. And there are people that poo-poo on that. And I just told you how much I hate radiating children. However, even if you use the most liberal protocol, we still miss injuries in these kids. And they can obviously be devastating. So this is one situation in which I have a low threshold to get a CTA because it's obviously life-changing if you miss it. I have no idea what that slide is, but okay. So these are, if you look at this, you can understand why it's very easy to get a CTA for a kid that you suspect a cerebrovascular injury in. So all the signs, right, like a bruit, expanding hematoma, okay, that makes sense. But then risk factors, right? Different facial fractures or indications, brain injuries, any cervical spine fracture or ligamentous injury. I mean, that's like any kid with how many kids do we see with ligamentous injuries, right? Like they technically could go get a CTA. Obviously near hanging because again, just the injury to the neck. But a TBI with thoracic injuries, a scalp degloving. I mean, blunt cardiac rupture, you got other problems, I think. But it's not hard to justify getting a CTA in a kid that you suspect for a cerebrovascular injury. So indications for head CT, we get lots of them. I think most of them are indicated. As far as the number of repeat head CTs we get, I'm not really sure about that. I don't think that our practice here is necessarily up to date. But as far as the initial one in a trauma patient, they're widely used and I think most of the time here appropriately. So I can get all of these to anybody who wants them. These are our kind of algorithms for when to scan heads and when not, and they're age-based. So we have one for less than 2 years of age and one for over 2 years of age that was built. But I mean, you can see that there are times where CT is not indicated and you can observe the patient, right? So these are meant to guide you and to help you. You don't have to follow them all the time. I think all CTs are overutilized. I think we're pretty good with CT heads here. I think we repeat CTs entirely too frequently here, but and it's on our protocol. We just don't, sometimes we don't follow our protocol exactly to the T, but again, there's always room for, physician discretion or provider discretion, I should say. We referred to C-spine clinical clearance. Not everybody needs a CT. Some kids don't even need an X-ray. So nexus criteria for verbal children. For pre-verbal children, there's a separate criteria. There's a very low incidence of C-spine injuries in young children. And even if you think, well, I don't know, I have kids that go get MRIs and they have ligamentous this and that, we find those injuries on MRIs and we treat them with a collar. But the truth of the matter is we don't really have good long-term comparative groups to say, are these clinically significant injuries? Okay, fine, you have a ligamentous injury. It's not unstable. We torture you and put you in a C-collar for 6 weeks. Did that matter? Was that for anything other than comfort? Would you have had a different clinical outcome if we didn't do that? There are some weaker studies that show that there's not a difference and that we find a lot of clinically insignificant injuries and treat them. And so then the idea would be then we don't need to scan them so much. But I think, again, just the prevailing taking extra caution, right? You don't want to have the one kid that ends up with a complete C-spine injury because you didn't put them in a collar or you didn't scan them. So, but just so you know, C-spine injuries overall are rare, and then, quote, clinically significant C-spine injuries are even more rare. This is nexus criteria. If anybody's having to clear somebody clinically, they have to be awake and coherent and not have distracting injuries. That doesn't mean that they can't have a femur fracture that has been stabilized. But if they're screaming in pain from their femur fracture, that is a distracting injury. The femur fracture, once it's been stabilized in pain and treated, as long as the kid's not passed out, whatever, and can focus on the exam, that's no longer a, quote, distracting injury. So as long as they don't have tenderness, the kid's not drunk again, or, they can cooperate with the exam and is alert, you didn't overdose them with fentanyl for their femur fracture, and they don't have a painful distracting injury, right? If all of those things are absent and they don't hurt when you touch the midline of their C-spine, you can clear them. And you have to differentiate between the midline of their C-spine and the paraspinal musculature, right? So if you've ever slept, well, at least me, I'm getting old. If I sleep wrong, the side of my neck hurts, right? That's muscular pain. That doesn't mean that I have a C-spine injury. So I palpate the midline, and if they say, oh, it kind of hurts, I'll palpate off to the side and say, well, does it hurt over here? And most of the time they'll say, yeah, that's where it hurts. And I say, okay, does it hurt on the bone when I'm touching right here? And they say no. So you just have to be very dogmatic about your cervical spine exam. Again, another one of our algorithms for how we image the C-spine. I can get this to you if you want it. NAT, I think this is big for a lot of our nurses on the floor, ER nurses, any provider really, because these kids can get caught in the ER, hopefully, when we see them, but sometimes they end up on the floor and nobody's caught it yet. And if you're doing an assessment, you can see something. So it's important for everybody to always be thinking about this, not just an ER doctor or the trauma team or whoever, right? So there are some red flags listed there. There are things that make sense, right? Like if it makes your spidey sense tingle, like you should probably think about it and ask some, it doesn't always have to be you pulling the flag. I'm not saying like you have to call CPS, but maybe just ask somebody else, what do you think? And get somebody else's input, right? Indicators, so things that you'll see, long bone fractures in a non-ambulatory child, metaphyseal or corner fractures, posterior rib fractures. Again, rib fractures and chest fractures, thorax fractures at all in a kid are not always, they're pretty uncommon, and they should make you think about it, unless the kid was crushed in a car accident, right? Then it makes sense. But a sternum fracture, a scapular fracture, all those are very, very high energy types of injuries. They don't occur from the kid just falling down, while running out in the backyard. We'll go through another little, evaluation tool here in a second. That'll list some of these other things. But obviously when we do exams or when we're concerned for NAT, we get ophtho to come and look at their eyes, right? Because retinal hemorrhages in babies that have been shaken. A torn frenulum is just, it shouldn't happen, right? Certain bruises and patterns of bruises and burns, obviously bite marks. cranial injuries, pancreatic injury, again, significant force to get that to happen because it lives back in the retroperitoneum in a child. So, well, in everybody, but it takes a significant amount of abdominal injury to end up with a pancreatic injury in a child. So this is what we use, and we just updated our non-accidental trauma screening guidelines and protocol here a month or two ago. And this is what's in our protocol, and it's called the 10-4 phases. And so it's another mnemonic. But if you see injury to the trunk, specifically injury to the ears and the neck are concerning. And then any bruising on a child less than 4 months of age is abnormal, right? They're not running around and falling down and hitting their shins into stuff. So that should always set you off. Again, injuries to the frenulum or inside the mouth, around the ear is abnormal. Patterned bruising. So they actually have pictures online. I mean, you can see like, oh, that looked like a belt, or that looked like a buckle handle, or that looked like, I mean, you can actually tell what the kid got hit with, and different types of patterns of burns as well. And again, just if it doesn't make sense that that kid has a bruise, then you need to think about it, right? Kids that don't bruise rarely bruise. So here's the ATV stuff that people had asked that we talk about, just ATV injuries, I guess, in kids and how they're maybe more susceptible or what things to look for. So just some basic background. In Texas, the law is that any kid under 14 years old is supposed to be supervised by an adult when they're on an ATV. And you and I and everybody else know that doesn't happen. So that's number one. You're going to get in trouble if something happens and they can show that you weren't around. And that there are, quote, child-sized and regular ATVs on the market, but the law does not recognize a difference. So if you say, oh, well, he was on a child-sized SUV, the POPO is going to say, we don't care, because there's no such thing in their eyes, right? There's no difference. AAP is the American Academy of Pediatrics. Their formal recommendation is that anybody less than 16 years of age should never drive or be a passenger on an ATV, which is very staunch. They do then go on to say that people that live in like really rural areas have to ride them to go to school and stuff like that. Like maybe there are exceptions, but then there's a whole outline of all the protective stuff and all the safety courses and all this stuff, right, to make that okay. And the bottom line is that anybody less than 6 should never be on an ATV. And then like 10 to 16 or so, like for those special circumstances, maybe, but with a lot of caveats. So this was surprising to me that it's estimated that every hour 4 kids present to the ER because of an ATV-related accident. Again, 90% of the deaths are in kids that are less than 16 years old and in adult-sized ATVs. And then interestingly, I guess I thought it would be more dangerous to be riding an ATV through the hills and the valleys and the dirt and all this other kind of stuff, but it's actually more dangerous on a public roadway, and it's because of how the tires are built. The way they're knobby and whatever, they grab on unevenly to pieces of gravel on paved roads, and so it'll like toss them over. So it's actually made to be an all-terrain vehicle, whatever, right? But it's meant to be like out grabbing onto loose dirt and gravel. When you put them on a paved road, it's actually more dangerous. And the number one cause of death from ATV accidents is a head injury. The CPSC, who I didn't even know who this was, but their Consumer Product Safety Commission, okay, fine. They also, in addition, recommend safety courses for everybody and wearing protective equipment, obviously, like a helmet, gloves, eye protection, whatever. Risk factors, age less than 16 and males, big surprise, no offense. The size of the ATV, again, these adult-sized ones that are bigger, smaller riders just can't handle it, and their center of gravity is not correct to be on such a big thing, and they can't shift their body weight. They're not strong enough to kind of correct when things start going askew. So the bigger ATVs are more dangerous, especially for kids. Again, being on a paved roadway, having a passenger in any circumstance, even if the ATV, quote, is made for 2 people, 46% of the deaths from an ATV are either the passenger on the ATV or an operator that had a passenger with them. So if you're an operator alone, you're less likely to get injured. But as soon as you put a second person on that ATV, either that passenger or the person who's driving with that passenger on, account for 46% of the deaths. And then obviously no helmet. I mean, nobody had to say that, but they reduce fatal head injury a significant amount, 40%, and then non-fatal TPIs, they reduce it by 60. Not surprisingly, the rate or the incidence of accidents on ATVs increased during COVID. 50 to 60%, so pattern of injuries, 50 to 60% are orthopedic injuries, so fractures. The older kids tend to have more serious, I guess I would say, fractures, more central, so spine and pelvis. Younger tend to be more extremity fractures. And they think this tends to be because younger kids get pinned beneath the ATV for longer and have, again, just the size of the ATV compared to the kid crushes them, and they tend to get an arm stuck under it or whatever, or hit by it, as opposed to older kids. Head injury is present in 35% of the accidents, most common in the younger kids. Also thoracic and abdominal injuries. Again, have to worry about the kids getting caught beneath the ATV and getting crushed or asphyxia, and also incidents of compartment syndromes and things like that. And 25% of all of these kids that come into the ER and get admitted require ICU level of care. I think the take home for ATV accidents in particular is that ultimately you would treat them like you would any other trauma. So again, the ABCs, you start your trauma assessment. I don't think it's safe to assume any specific pattern of injury necessarily. I don't think that it makes sense to come up with an algorithm. I mean, you just look at the kid and does he have a broken arm or not, right? You treat them like any other trauma. You can maybe have a higher level of suspicion for head injuries or extremity fractures, but it doesn't mean you're going to rule them out necessarily just because, oh, that's not common. Don't forget about compression injuries and compartment syndromes. And in my head, I just treat them like an MBC with ejection, or like somebody that was on a motorcycle or something like that. So I don't think there's anything special to think about other than to understand that they seem extremely dangerous to me, and I can't imagine any reason why I would want to be on one, let alone put a small child on one. They also went into detail about adults putting their 2-year-old on there, right? Like the adult is driving and the 2 or 3-year-old is in front of them. And again, no child under 16 should be on one, and certainly nobody under 6, according to the AAP, but that those kids can do stuff that distracts the completely competent adult, right? They can move around, or they can put their hand on something, or they can twist or do whatever and distract you, and then that causes an injury. So not just the child not knowing how to drive an ATV, but having any child on there, it can be a distraction as well. So that's where that kind of staunch recommendation to just don't put your kids on ATVs makes sense to me, but whatever. I think that's it. Those are just some references for the ATV stuff. And I think that is it. Do you guys have any questions? Okay, if no questions, that's all I had for you guys. If any of you guys want copies of any of those protocols or algorithms, you can email me, or I can send them to Kelsey and maybe she can send them to you. Have a nice day.
Thank you so much, Dr. Fike. That was a great presentation. Thank you everyone for attending. We will post the survey in the chat so you can receive your CNE information. Let me know if you have any questions. We're always here to help. Thank you so much.